This program will explain how nurses and other healthcare professionals can use the PLISSIT model to assess the sexual issues and needs of their patients, and how to work with an interdisciplinary team to find strategies to help patients overcome barriers to sexual fulfillment. Sexuality goes beyond the sex act. For many older people, it is an expression of not only passion, but affection, esteem, and loyalty. It carries with it the possibility of excitement and romance. It expresses delight in being alive.
So Mrs. Benson's a 73-year-old white female. She was admitted a couple days ago and had a right mastectomy related to a carcinoma that they had diagnosed there. Post-op period was completely unremarkable. The incision's healing really nicely, and she's doing really well. Vital signs have remained stable. She has a previous incidence of hypertension, and so she's being treated with some antihypertensives for that. Has had a little depression in the background, and she's continuing to take Zoloft for that, which seems to be managing her depression fairly well. She's on a few vitamins. She's got a little bit of arthritis that she feels is controlled with over-the-counter medications, and overall is in fairly good health. She's been married for 52 years to her husband. I've brought with me today a student nurse. This is Kate.
Hello, Kate.
Hi, Mrs. Benson.
And if it's okay with you, she'd just like to be present as we talk a little bit.
That's all right.
So I heard you're going home today.
Yes, I can hardly wait.
I bet. You've been here a couple days, so it's nice that you'll be able to go home. If it's okay with you, I'd like to ask you a couple questions about your sexual health.
That's all right.
At this facility, we want to make sure that you go home prepared with any information that you will need, especially after the breast procedure that you've had, where you've had your breast removed. Sometimes there's some changes in your self-image that might go along with that, and that could impact your sexual health in the future. Also, as people age, there's a number of both normal and illness-related changes that happen to your sexual health that people don't always talk about, but really very important to address. So I want to just begin by asking you what concerns you have about your sexual health as you get ready to go home.
I think that my major concern at this point is my body that is so changed, and it's difficult for me. I can't imagine, and I don't know how my husband is going to react to my body when he sees me like it is now, because it's always been something. My body has always been precious to both of us, and I'm very concerned about how he might feel, whether he would be afraid to touch me, that he might hurt me, or just might not want to even see me. So I'm really concerned about that.
As you have gone through your relationship with each other, have there been other points in time when your sexual relationship has changed?
Oh yes, oh yes. We have always been affectionate to one another, but as you get a little older, you're not able to perform as often or as passionately, but you graduate onto different levels of sex, and the touchy-feely, compassionate, loving, and caring about one another come out more. If you really love one another, you really don't have anything to worry about, because love does find a way. But I'm concerned because I know that in the past my husband had a blood pressure problem, and he went on blood pressure medication, and so he was not able to perform the way he would have liked to, or the way he was used to. Some things do change. But he asked his physician about changing his medicine, if that was a possibility, and his doctor was able to adjust his medication so that we were able to have at least missionary type sex, which was fine. Then something nasty happened to me, and I was premenopausal, then I was menopausal, and I must say that at many times sex was very uncomfortable, and I just as soon forget about the whole thing, but I felt that I wanted to be loved, And I wanted my husband to be able to love me in any manner that he wanted to. So I asked my physician about something, and she was able to put me on a very low dose, the minimum low dose of hormone replacement therapy, and that helped me quite a bit. Now we're coming into a different stage again where the touchy-feely, checking out one another, I can't wait to get in bed even now and just sort of get into my husband's arms and have him caress me and love me and hold me. I need that. And I hope that we can get back to that, at least that stage of loving one another. And I'm looking forward to some help, perhaps talking to someone and finding out just how people manage. So I'm looking for help, and I hope that you can help us.
Well, it seems certainly from your experiences before that you worked very hard with your husband and your clinicians to resolve the issues. So I'm very confident that we can help you to resolve any issues that might come forward because of your breast surgery. You've experienced some really very common problems of aging. The first thing you had said about your husband with high blood pressure is very common as people get old. Heart disease is a very common problem with people who are aging, and a lot of people have concerns once they're diagnosed with a heart disease. Can they even have sex at all? But there is a rule about that, and I can't quite remember what it is. Do you remember?
I think the recommendation is that if you're healthy enough to climb a flight of stairs, you're healthy enough for normal sexual activity.
We have lots of stairs. We're in good shape. That's wonderful to know. I didn't know that.
And also what you had said about the vaginal dryness
yes.
is very common among women as they age and they go through menopause. And the way you had worked that out with your clinician seemed to be a very effective way to do that. And we can talk about that a little bit more as well as we put together a plan of care for you to go home and enjoy your sexual relationship in the way that you and your husband have desired it. What I'd like to do, if this is okay with you, we have a geriatric team here who have lots of expertise in both of these problems. I'd like to bring back the information from this assessment, work with them, and develop a plan of care that we think will address these issues and that will help you to return to your state of sexual health when you go home. And then, so I'll meet with them if that's okay, and then I'll come back and we can talk about the plan of care and get you ready to go home. Okay.
Thank you so much for your help. You've been wonderful.
That's my pleasure. We'll be back in a little while.
Thank you. I look forward to it.
So that was a lot easier than I thought it was going to be.
Do you think so,
Yeah.
really? Because actually that was pretty typical of what a normal sexual assessment would be. I think a lot of nurses and a lot of students believe that patients would be very embarrassed to discuss these kinds of things, but that has not been my experience at all. Most patients are very forthcoming with information. They'll give permission for the assessment, and then we'll provide answers to a clinician's questions when they're asked, and are in some cases really relieved to be able to provide information that will help to ensure their sexual health. I can't actually even remember too many situations where patients were not forthcoming or embarrassed. Yeah.
So what would I do if a person was embarrassed or not really forthcoming with answers when we're doing the assessment?
Sometimes those issues come from bad timing,
Right.
And so it's not always appropriate to ask questions about sexual health, especially when patients have so many other things going on, so many priority health concerns that they're not really thinking about sexuality. And in some cases, they might be uncomfortable if you were asking a question to a patient who is of the opposite sex. So if you were asking a question to a man, he might be more forthcoming giving information to another male clinician as opposed to a woman. So in those cases, if you were to find that a patient were embarrassed, just say, I can understand that you don't want to talk to me about your sexuality, you're not comfortable talking to me about sexuality. Would you like to postpone this conversation to another time, or would you be more comfortable talking with another healthcare provider? And those might be able to at least get you on the path to a good assessment and appropriate plan of care.
Would you do the assessment on a person regardless of whether they were married or single?
Absolutely. And in fact, we don't ever want to make assumptions about a patient's sexual orientation. Some clinicians ask, how do you consider yourself heterosexual, homosexual, bisexual? I generally try to leave it open. I really always avoid terms like husband, wife, spouse, and leave it as partner. And that is open to all sexual orientations and will allow you to provide provide questions that will get at information that's pertinent to the patient in whatever sexual orientation they might be. And so we never want to assume that someone is not sexually active. The other issue that comes up is clinicians often assume that if a patient has a partner, that that's their only partner, and that's not the case as well. So you want to be open to the fact that the patient might be having a sexual relationship with a number of different partners, so that you can make sure to ask appropriate questions regarding safe sex and be able to provide a plan of care that will make sure that they're safe in all sexual situations.
Okay. Are there any circumstances under which you wouldn't ask a patient these questions?
Well, sexuality is a continuing human need, so it will be part of the plan of care for all patients. But it is a situation that you have to look in terms of priority with other healthcare concerns. If we had asked Mrs. Benson these questions the day of her surgery, that would not have been appropriate. The fact that she's going home today makes it very appropriate to address these sexual issues with her, because this is going to be a problem that she's going to have to manage at home with her husband. And so really timing is the most important thing, but we always want to make sure not to miss opportunities either. Do you have any other questions or concerns?
No,
or I
think that's it. I think I understand it pretty well.
Okay, so what we're going to do now is meet with the rest of the team, the geriatrician and the geriatric nurse practitioner. I'm going to present the concerns that Mrs. Benson had put forward when we did her assessment in her patient's room. Okay, so thanks everybody for coming today. This morning earlier, Kate and I did an assessment of Mrs. Benson. The plan of care is really going to be focused on her sexual health, which is an issue that we're really trying to address more and more with our older adult patients here. We asked her a number of questions about her sexual health, and she was really very forthcoming with the information, wouldn't you agree? But seemed to have a lot of concerns about how her husband was going to react to her coming home and having this breast surgery. She has the incision in the area. She did have reconstruction. So really she's afraid that her husband's not going to want to touch her, and that and he's going to be afraid to talk about it as well. And so what can happen, I think, as we all know in this situation, is one thing can lead to another, and their sexual relationship could really suffer from this. So we want to address that issue. And she also, during the assessment, had brought up kind of a long-standing issue that they have had where menopausally she was experiencing some vaginal dryness and had reported some really very painful intercourse with that. Her physician had put her on a low dose of estrogen replacement, which seemed to have worked a little bit, but she was still complaining of the vaginal dryness, so she was looking for some help with that as well. So let's deal with the most pressing issue at this time, which is her altered image because of the breast surgery. Any suggestions help with that?
Can I just ask a question? How has the husband responded to this whole treatment process, the surgery and the like? I mean, has anyone asked him how he feels about this?
That's a really good question. Did you get any idea from Mrs. Benson what her husband's reaction has been so far?
Well, I think that mostly we got from her that that he seems anxious about what's going to happen when she comes home, and that he's worried about maybe hurting her with touch, and that she's very worried that he's not going to want to talk about it with her.
And you know, that's been actually looked at in the literature, and that's a very common response with major surgery. One partner who has the surgery is more concerned about what the other partner is how they're going to respond to that, as opposed to the other person feeling, I don't want somebody to get hurt and the like. So, you know, one thing that I always do is explain in as much detail as possible what surgery was done, what the physiological effect or lack thereof of the surgery is going to be on normal sexual function, and make sure that both parties are present for that. I mean, clearly this is a team, and we have to approach their care as a team for this issue and other issues, and explaining to both of them together that, you know, physiologically there's going to be really no change in sexual function, and also discuss other options for intimacy that maybe they haven't thought about, or maybe that was not part of their normal routine.
Those are really good suggestions. What do you think we should do? I don't know if her husband is going to be back here for the discharge summary. Can we give her information and maybe some language that she could use to share with her husband?
I would keep it simple.
Okay.
Many times in the health profession we feel comfortable throwing around medical terms because then we don't have to really express how we feel or give the right advice. So I wouldn't give her a wealth of information about, you know, what muscles were cut and this and that. I would keep it very basic and simple and reassure her that, and to make sure she understands and can tell her husband that there really is going to be no difference once the wound has healed. and to try to not hide behind medical jargon when we're describing this to them, and focus on their feelings about each other, not each other's, perceptions that things have changed.
That's a good suggestion. In terms of weeks that you think that they might be able to return to sexual health, I know sometimes patients really need some very tangible information that I'll feel better participating in sexual relationship and at this time. What's your impression in terms of recommendations?
Take it slow. And it's interesting, some people kind of change their normal routine after a major life event like this because they almost want to overcompensate. And I don't usually recommend that. I say just kind of follow your normal routine, take it slow, don't put unrealistic expectations, and if one or both partners says, I really am not interested in doing this now, be comfortable with that and don't overreact to that type of thing. So stick to kind of your normal routine, although at times that can be difficult. I don't know if you have any other suggestions in that regard.
No, I agree. I think taking it slow, again, maybe give some contact information so that they have some resources that if they do run into a problem, or even just to talk with someone about some of the new issues or maybe an issue that is kind of lagging and they would like to work out.
We're always more comfortable telling people to talk to someone else about the problem, but we clearly want them to talk to each other.
Right.
And anything we can do to facilitate that, I think, at least in my experience, would be the most beneficial.
Yeah, I think you're right about that, and I think your suggestion about having the partner involved in the original discussion is the most helpful, because that gives them the opportunity to provide that information and to ask questions while they have a healthcare provider there.
There are occasions where particularly the man may say, I don't want to discuss this with anybody. This is too private. I think this is kind of a man issue as well. And I don't know, we have to be creative in kind of dealing with that as well.
I've had patients who were not comfortable talking about sexuality before, and I generally have gone to them and said, okay, well, would there be another person that you might be more comfortable talking to it about, or perhaps we can schedule another time when it sounds like it might be more comfortable. Even giving them some time to think about some questions and that kind of thing might give them more confidence to be able to discuss that. Yeah. In terms of the vaginal dryness that she was thinking about, I've recommended to patients in the past that they use some of the over-the-counter jellies, the KY jelly, things like that. Any other recommendations that you've thought of?
Well, this is not an uncommon problem, and it might be caused by something like atrophic vaginitis, where maybe topical estrogen in low dose might be helpful. Once again, the main problem is discussing it with patients. They're not comfortable discussing it. The other thing is that the typical older person uses 6 to 8 medications, 2 to 3 which might be over the counter. Many of them have components, anticholinergic components, that can specifically cause this. So you want to check the other medications, and you don't want to give one medication to counteract another medication if it might be a contributing factor. So doing a good general medical history, reviewing medications, I think, is also part of the approach.
That's an excellent idea. So I can ask Mrs. Benson to perhaps meet with her healthcare provider specifically on this issue, reporting this. I can help her to develop the language to do that if she's not comfortable with it. And then we could look at her medical history to see if there are other medications that are contributing and medical interventions really that might work to help to resolve that issue for her.
Would it also be important to encourage her to take a little bit more time before actual penetration to allow her to lubricate herself a little bit better? I know older women tend to have difficulty at postmenopause with vaginal dryness, but to also just encourage her to give herself just that extra period of time to allow herself to lubricate more.
Yeah, I think that's a really great idea, and I think also based on our assessment of her this morning, it seemed that she and her husband were very open to snuggling, and perhaps that area of their relationship could really be promoted, which would enhance lubrication and allow for better sexual intercourse for her, less painful, less dryness. I think that's a great idea, so we will definitely add that to the plan of care. Okay, so I think I've got some really great interventions. Any other ideas that you guys can think of, any concerns?
Yeah, I just want to mention one thing about, she does have a history of depression, and we know that typically in older patients, depression is underdiagnosed and undertreated. In situations like this, if there is a period where she might be a little more depressed, then maybe her medication and or counseling has to be increased or, managed a little differently. So just to let her know that because she's on an antidepressant, it doesn't mean that there's not all that can be done. There are adjustments in the medication, maybe an alternate medication, and to be very sensitive to how this whole experience is going to affect her mood and level of functioning.
Okay. Right, that's great perspective. Good. Okay, so it sounds to me what we're going to do is provide some very basic teaching to her in terms of what was done for her surgery and the structures that were involved, and give her some really clear guidance in terms of when she could expect to feel better and participate in her sexual relationship again. That in most cases it would be great if we could have her husband there for that teaching and that counseling session, but if that's not possible, we could provide her with some information that she could share with him, and maybe even do a little bit of a role play so that she could feel comfortable talking to her husband about that. We talked a little bit about normalizing, taking things very slowly and returning to their normal sexual patterns as they feel comfortable, but not pushing themselves to a point that they really feel that this is absolutely urgent, that they have to get back there. Not to have unrealistic expectations about sexual health, but to really let it come from their hearts and when they feel comfortable doing that. We also felt that Mrs. Benson would really benefit from a very good examination with her primary care provider to look at issues that might be causing some of this vaginal dryness in terms of some of her medications, and to really look at that as a medical problem that might be amenable to some topical estrogen treatments. And then also the suggestion that Kate had made in terms of really building up their use of snuggling and foreplay to enhance that time for vaginal lubrication might be helpful. And then also, as a cautionary note, we do remember that she does have this history of depression, and that her, because of her disease and some of the recoveries period that she's going to have, that there is a possibility that her mood may be affected, and we want to make sure that she talks to her healthcare provider about that as well, and make sure that she gets appropriate management of that depression if that's an issue. Did I capture everything?
Yes, and I would just leave one more kind of optimistic note with her, is that the vast majority of people after this type of surgery are able to readily assume their normal sexual level of functioning, and she should focus on that and realize that over time, just as her body heals, everything should kind of get back to where it was.
So what I'll do is take the plan of care that we seem to be developing here, and I'm going to go back to Mrs. Benson. She's going to be discharged this afternoon, and I will give her our suggestions and let her know that she can contact us at any point in time if she has concerns or questions in the future, and we'll go from there. So you look like you're all ready to go home.
Yep.
Kate and I met with the rest of the geriatric team. We had a geriatrician there and a geriatric nurse practitioner, and we've come up with some ideas we just wanted to discuss with you to make sure that you could maintain your sexual health after you go home and get settled in and things like that. Dr. Cairns, I think, did a very good job, the geriatrician in the meeting, of telling you that most people who have this procedure return to a very normal sexual health life, and so yours will come back as well, and a little work toward that would certainly speed it along a little bit, but overall he felt that you should be very optimistic in terms of your sexual health returning. Don't feel that you should have any unrealistic expectations. If you don't feel sexy right now, you don't feel like having a sexual relationship with your husband, don't push it. And feel very comfortable to talk to him about that, making sure that he knows also that it does take a little bit of time to heal, and that you guys should just continue to keep your lines of communication open, talk about it, and maybe set some dates when you both could try it. If it doesn't quite work out, maybe set another date that you could try it again. Kind of just keep plowing along.
Meredith goes on at this point to discuss the other recommendations from the team meeting with Mrs. Benson.
And I think just to end, I want just for you to be assured that you really have a very solid foundation for a good sexual relationship with your husband, and there's really no reason to think that that will not return to normal as you're recovering from this procedure. So if you have any questions or concerns, you can call me at any point in time, and we're always happy and here available to help you.
And I do so appreciate your help. You have been so helpful to me.
Oh, you're very welcome.
You both have been, and it's a great comfort to be able to talk to you and to have you for myself. This is very good.
Well, it was our pleasure. Thank you for being so forthcoming.
Thank you, thank you.
You're welcome. interestingly, we really don't know a lot about the sexual patterns of older adults. It's a very poorly studied area, which is truly unfortunate because if we had more information on how sexuality changes as people age, we would have a lot more information to be able to help older adults as they experience changes with aging that impact sexuality. We've had a few larger studies. There were some Masters and Johnson studies done fairly early on that showed that sexual patterns continue to exist throughout the lifespan. And their more recent study done in 2007 showed that about 25% of even old adults in their 75 and 80-year-old area we're still continuing to have sex. So that shows us that those patterns are continuing throughout all lifespans and gives us some data to at least know that this is an important area for older adults and an area that we should continue to address. And I think it's true that if we asked more questions about sexuality to older adults, that we would definitely get some more information. Most healthcare professionals have gotten very little training in geriatrics in general and almost no training and education in geriatric sexuality. So that, of course, is a very large problem and prevents many healthcare providers from having the comfort level sufficient to ask sexually oriented questions. There's also the problem that there's this general myth in society that older adults are not sexually active. So I believe that it's true that many healthcare providers don't ask sexually oriented questions to older adults, questions about sexual health, because they don't believe that they're sexually active. Because they have many healthcare problems as they continue to age, the average older adult has 3 chronic medical illnesses. Those illnesses impact sexual health, and they need healthcare providers' assistance to maintain their sexual health. And so it's almost borders on negligence for healthcare providers not to ask sexuality questions. It's almost, in my opinion, as if healthcare providers didn't ask questions about nutritional levels or levels of activity and exercise or levels about how they're feeling or shortness of breath and all of those other really important systems. It's interesting to think why sexual health would not be given that same focus in terms of assessments. One thing that we know with older adults is just through the normal aging process, in absence of any disease, that there are changes that older adults experience. So as older women go through menopause, there is some vaginal dryness that is experienced. There's some change in body image that women need to adjust to. There's some alterations in periods of time when they're feeling more sexual than other times. So those are just normal things that older adults often bring as problems that interfere with their sexual health. In terms of aging men, we do know that as men continue to age, that there is a normal decrease in the amount of erectile function that they have. So as men continue to age, erectile dysfunction increases in incidence. So that's a problem that often older men experience as they're aging. And then you add on top of those normal things, diseases. 2 of the very most common diseases in older adults are heart disease and depression, which both impact sexual health immensely. And so to think about some of those normal and pathological changes, you can understand that there's lots of ways that healthcare providers could intervene to help older adults to promote their sexual health. The PLISSIT model was developed in the 1970s as a model to guide sexual assessment and management, and it's been used extensively since that period of time with all populations, not just older adults. It's nice because it's very easy to remember and just provides a general framework with which to gather information about sexuality and plan care. So it begins with the P, which is asking permission to talk about sexuality, and because this is a very intimate topic, it's very nice to ask older adults their permission because it gets their buy-in to the sexual assessment. It gives them control over the assessment and the amount of information that they want to share with the healthcare provider. The LI in the model provides limited information. So in this case with older adults, we can provide information on the normal aging changes that might impact sexual health, and then also disease-specific changes, like in the case with Mrs. Benson where she had a surgical procedure that could impact her sexual health. We could talk about that, and then she also had a normal change of aging that we could address as well. The SS in the model provides specific suggestions suggestions, and that gets into our plan of care. And often we can do that, as we did here, in a team setting where we come up with some strategies to help older adults to promote their sexual health. And the IT in the model provides for intensive therapy. And in the case of Mrs. Benson, where she had some changes in her structures, her bodily structures, that it could impact self-image, that would be very appropriate. Sexual assessments require a very private, very confidential environment, and we also want to make sure that we choose our timing very wisely. When an older adult is acutely ill, is not a good time to talk about sexual health. They're not thinking about sex, they're not wanting to plan care for sex. So really, while the older adult is thinking about the future, getting ready for discharge and looking toward their recovery days, that's a good time to start talking about it. And in the privacy of a room where there's not a lot of people around, where they're not worried about being overheard by anybody else, that's absolutely critical. It's also very helpful in doing a sexuality assessment to have a pre-established relationship with the client. It's not always very easy to walk in, introduce yourself to a client, and ask them to talk to you about sex. So establishing that relationship through the development of a plan of care, which might address other health-related areas, is often very important before you start to get into the sexual health issues. Anyone, any clinician can do a sexuality assessment. I'll be completely honest with you, it gets easier if you do them more often. And I often encourage nursing students just to start asking the questions. The more you ask the questions, the more comfortable you will be with providing that assessment for an older adult. Never assume an older person is not sexually active. Never assume that they're only having sex with one person. Never assume that they're having heterosexual sex. Really being open to the fact that older adults are sexual human beings allows us to be able to do these sexual assessments with all of our clients, regardless of what age they are. The assessment shouldn't take very long at all. Just in the case of Mrs. Benson, should take less 5-10 minutes, should be appropriate. If there's lots of concerns about sexual health, then it might take a little bit longer. But a normal assessment, I would say less than 5 minutes. You want to start with that permission. You want to say something like I said to Mrs. Benson, similar to, I would like to ask you a few questions about your sexual health. Would that be okay with you? And again, that puts the patient in the driver's seat, gives them control over the questions you're going to ask. They know that they could say no at any time or refuse to answer your questions. And that's just a great way to start. After that point, it goes very natural. You ask a few open-ended questions such as, how has your sexual health changed in response to your illness or as you have aged, and that generally will provide a lot of information with which to go on in the assessment, and you can take your cues from that point. There's lots of cultural issues that patients bring to surrounding their sexuality and bring to sexual assessments, which we need to, as clinicians, be very respectful toward. So that, I think, is one issue that prevents a barrier to sexual assessment. The overall myths that empower healthcare providers toward preventing sexual assessments are something that I think are challenging as well, and trying to negate some of those myths and dismiss some of those stereotypes would, of course, be very helpful. In patients who come to the healthcare setting from a different cultural background that perhaps makes it more challenging to assess sexuality because of their culture, we often will have to postpone the assessment until we're able to gather further information about their cultural background. Generally, if a patient is hesitant because of their cultural background, you'll find that out when you ask the permission. They'll say something like, no, I'm not comfortable talking about that. And so you could always gather some more information about the cultural background and try again at another point in time, or try to direct the assessment toward areas where they might be more comfortable, and then use that to give you further information about their sexual health. So, for example, maybe they're not comfortable about talking about their sexual relationship directly, but they might be willing to talk about their relationship with their partner, and that could help to give some information about whether there's some sexual health issues at that point in time.
Well, sexual assessment is a little bit different because there's lots of normal and there's lots of abnormal, I suppose. And we really, because there's so limited research in this area, we don't really know what's normal for an older adult and what's not normal. So that has to be patient defined. And in the assessment that we did with Mrs. Benson, we continually alerted to the fact that whatever they're comfortable with in terms of the frequency and the quality of their sexual relationship. And so it's a really patient self-defined situation. If patients are happy with it and comfortable with it, it might be very different from what the healthcare provider wants, but that's not the goal. The goal is that patients are feeling sexually healthy and that their sexual needs and desires are met. There's a couple resources that are very helpful to helping clinicians to determine how and when to do assessments of older adults in terms of their sexual health. One thing is that there's an article coming out in the American Journal of Nursing that will provide lots of information on how to conduct sexuality assessments and what to do with the information that's received. And there's also information on the Hartford Institute for Geriatric Nursing out of New York University's website, which could be very helpful to clinicians interested in this topic. And then finally, the AARP, the American Association of Retired Persons, has some information on their website. They conducted a couple studies on sexuality in older adults and are very helpful in helping older adults to manage their sexuality. So those are a couple resources that I think might be helpful.